Good afternoon, everybody. Welcome to another Wednesday afternoon live stream from the C3 Foundation office here in Florida. How's everybody doing out there today? I see we've got quite a good crowd. Who's out there in our chat box today? Oh, I see Nat. Hi, Nat. Nat says, hi, Robin. I don't know if you have your Twitch on. A lot of people don't because of bandwidth issues. All right, we got Annette out there today and Aveen and Mudforce, a lot of our regulars. So already we are crossing continents, Robin. So we've got some of our UK watchers out there. Is our sound good today? I'm assuming, since you guys are answering me. All right. Hey, N. Smith. All right. Sounds like we've got good audio. With me today, I have Robin McIntosh, the co-founder and co-CEO of Workit Health. And Workit Health is one of our co-presenting sponsors for our upcoming virtual conference, which is a month from today on June 12th. So we are excited about that coming up, working on the schedule. So Robin is an experienced entrepreneur, designer, and builder. Robin has founded multiple companies and has worked across startups, brands, and business communities over the past 10 years. Robin's expertise lies in crafting and executing business growth strategies, as well as building innovative and compelling consumer experiences. A designer by training, she excels at solving industry-scale problems through user-centered research, design thinking, and craft. She's a frequent speaker and guest lecturer, most recently at Stanford, Yale, and the University of Michigan about design, innovation, and business strategy. So, and of course, as the co-founder of Workit Health, that means that a lot of Robin's job is helping people to access the Sinclair method through telemedicine. So, Robin, why don't you tell us a little bit more about, why you got involved in starting Workit Health and what that means to you?
Sure. Thank you, Jenny. And thank you for that intro. It's hard to hear that read about yourself. You're like, oh my goodness. But thank you so much. And thank you for having me, it's such a pleasure, such an honor to be here. And I'm just really excited to have this conversation. So why we started Workit Health. So the most important part, I think, of my bio that wasn't in there was that I'm in long-term recovery from alcohol use disorder. So an alcohol use disorder paired with comorbid with an eating disorder. And so I entered recovery back in 2005. And so it's been a second. And my journey is much like anybody else's journey. So I relapsed a bunch of times. At the time, I didn't know about TSM. I didn't know about the Sinclair method. I really wish I did. I was someone that dealt with a lot of physical cravings. I was very physically, viscerally addicted to alcohol. So what happened for me is I started drinking at a really young age. I started drinking as relief from my eating disorder, which is anorexia and bulimia, which I think is important to state. Sometimes we only focus on one thing, acting like we're two-dimensional people and we're all messy and we're all multidimensional. And I think that's important to understand how cross-addiction, comorbid addiction comes in. So I drank really because I was struggling so much with anorexia and bulimia, which was in reaction to other things. So it kind of is a stair step or a waterfall. But so I tried my first time trying to get sober when I was 17. And I went to my first rehab, and fast forward to age 21, and I went to my last rehab. And really what worked for me was a combination, I think, of community support. That was really important. And it's really an interesting topic that you brought up pre going live, to talk about community and connection and resilience and how we do that in this crazy era of COVID. But community support, medication, really good clinical help. Really good care teams. I was very lucky, and just time. So that in concert, I was able to get sober, stay sober, and remain sober until now, 2021. But to go back to Workit Health, I, like you read in my bio, I come from the world of design and business, and I was in California for a long time. And, I got to work on all these incredible projects. I was working on diabetes interventions, all these healthcare interventions, but nobody was touching addiction. Nobody was touching alcoholism. And everybody around me was suffering. Everybody around me seemed to be having issues, as always, right? Like we're always kind of the underserved class in healthcare. So it kind of came to a head in 2015, I would say. One of our friends passed away, which was this horrible event and rocked our whole community. And we just said, this is ridiculous. Nobody knows how to access treatment. Even if you can access treatment, nobody can afford it. Not everybody, the abstinence on or off the wagon does not work for everybody. This is insane. We're just letting the best of us die. So my friend at the time, co-founder now, Lisa McLaughlin, and we met actually in an AA meeting, in 2009, earlier than that. But in 2015, we created Workit Health, and we really did it to kind of dive into the question. In the United States, I know we have a lot of international listeners, but in the United States, 20 million people are diagnosed annually with a substance use disorder. 9 out of 10 of those that need treatment don't get treatment. And even treatment meaning, how we traditionally thought of it, rehab. And even if they go to rehab and they take that risk, a lot of them relapse within the first year. A lot of them relapse, frankly, within the first month. So we really dove into why. Like, why does this happen? Why do some people get well, other people don't? Why is there this huge discrepancy? And we kind of surfaced 2 reasons. So one, accessibility. And so that's why we're here today. It's to make this more accessible, right? Like, this is the reason we want to shout it from the rooftops. There are solutions out there, and there are choices out there. And the second one is affordability. It's really expensive. I think health plans are doing a better job covering treatment and providers that do TSM, et cetera, but still we have a long way to go with affordability. So that's Workit Health. So we started it in 2015. And then, we've quickly grown. We have an OUD program, an AUD, opioid use disorder, AUD, alcohol use disorder. Those are our 2 main programs, but we treat a bunch of co-occurring disorders as well.
And how important do you feel the switch and acceptance to telemedicine has been in the fight against substance use disorders?
Yeah, I think it's hugely important. Like, even when I was getting sober back in 2005, 2006, you didn't have telemedicine. So I had to go in person to all of my appointments. Oftentimes, my psychiatrist would recommend a great therapist, but I would never call them because I was in my worst, most vulnerable position in life. Like, it's really important, I think, first and foremost, to close the gap of treatment. So before we were kind of stitching together this constellation of different resources, my AA meeting across town, and then I go to my psychiatrist across town, and then maybe it would conflict with my work schedule. Telemedicine offers this real accessibility. I've seen patients drug test from a Starbucks bathroom. I've seen them take a shift at work, a break at work, and then call their counselor. Like, it's really, truly incredible that now we can beam recovery in one coherent solution into the homes and the lives and the workflows and the busy routines of the people we're seeking to help.
So what do you think some of the challenges are for someone who is just beginning to think about telemedicine as opposed to going to a traditional office setting?
Yeah, I think it's scary. I think it's really terrifying. Well, Google is not your friend in this case. We call it the Google K-hole, like, I don't know if I can say that, but like you Google
We're all adults here.
Yeah, all roads lead to South Florida, at least in America, and I'm sure the UK has the equivalent of South Florida. I don't know if it's whatever, but Spain or Croatia or something. But it's really difficult to find information. It's really difficult to vet information. I think it's challenging because you're so scared. And it's still so stigmatized, when we see people come in for their first appointment, via telemedicine, of course, their blood pressure is through the roof. they're really nervous. People are really nervous, especially if you're doing something illicit on the side, right? Like you're really terrified. And I think the fear there is, I always heard about an inpatient rehab. This seems unfamiliar. Will it really work? Will this really be able to replace the face-to-face contact I would have with a provider? So I think it's fear and skepticism. And those are the two challenges.
But then how quickly do you see that people then accept that as actually being less stigmatizing and more convenient? Does that process take a little while for people to really start to grasp it?
I think this part is I think it's an easy hurdle in some ways and the hardest in the world in other ways. I think taking that first step, turning on your Zoom and looking at your provider is a really crucial, hard step, but so is walking into your first meeting. So is walking into your first provider appointment. Those steps are really hard, and they're going to be hard in Zoom land, and they're going to be hard in brick and mortar land, like face-to-face land. But once you cross that, I think once you look somebody in the eye, you hear them laugh, you hear them, this is a good experience, but you hear kindness and you hear acceptance, then I think it's very easy to realize, okay, this is really beneficial and I'm on my way. But it's taking the first step.
And as someone who has walked your own recovery journey, and now you've dealt on the business side with telemedicine and on the personal side before that was even in existence. What can you speak of to the benefits of telemedicine in general?
In general, it's a great question. In general, like I look back at my experience, and it was so difficult in 2005 in Ann Arbor, Michigan, to find a good meeting. And it was so difficult to find a good therapist. And I was really young and ridiculous. I mean, frankly, like I pulled a lot of antics. Like I just didn't have my head screwed on straight at the time. I'm a little better now, but it just was such an obscenely hard task at the time, right? But if I had had telemedicine, if I had had an app that I could tune into, sign up for, toe dip, look at their blog, look at their resources, understands kind of some patient-centric stories, hear from their providers, maybe on YouTube or on Vimeo, whatever, I think it would have been a lot easier. It allows people to start the process of getting well so much sooner in their journey. This idea of hitting rock bottom before you get help is so antiquated and has frankly killed so many people. I mean, it's dragging us all down. It's just not true. Like the elevator gets off on any floor, and that's why I love the Sinclair method. That's why I love moderation and harm reduction policies. Like it's so much more modern.
Yeah. In this day and age, forcing somebody to hit rock bottom just because there's an addiction involved. I mean, you wouldn't wait for somebody to have their cancer move to stage 4 before you said, "Oh, you know what? We should do something about that." Oh, you're finally bad enough for us to pay some attention to. And so it does allow for almost more of a preventative now that we've moved from alcoholism to alcohol use disorder and recognizing the progression of a spectrum.
Yes.
Because anyone who is at risk that can be stopped before they become mild AUD or your mild AUD from escalating to moderate or severe. I like to tell people that, harm reduction and abstinence are not at odds with each other. Abstinence is just harm reduction taken to its fullest extent. Yep. They both reduce harm. It's just a matter of degree.
For years, like since the inception of AA, like I think when we think of 12 steps, we think of abstinence, but I don't know anyone that hasn't relapsed over and over and over. Like my sponsor at the beginning of, my AA journey was like, don't worry about it. Just do the work. All you need to do is show up and do the work, and like, it'll take care of itself. Right. And there's some problematic thinking in there too, but for the most part, I still believe that. I think this idea that we have in the recovery community where it's so bifurcated between harm reduction, abstinence is a complete, like, I just think it's a complete waste of time.
Yeah, I agree because also the sooner somebody does decide to change the role alcohol plays in their life, whether that is with a goal of moderating or a goal of abstinence, the sooner it happens, the more likely they're going to be successful at it because the problem has not been given the time to spiral out of control. The repetitive reinforcement, you cut that time out too. And, and when you can do that, and that's why I love telemedicine in particular, is because it's so convenient.
Yes, and private.
It's private. But one of the things that we really want to talk about is how to empower people who are using telemedicine services to get the most out of what they're paying for. Yes, it's a lot less expensive than your traditional detox 30-day rehab stay. However, every dollar is still a dollar, no matter what your budget. So if you're paying for something, you want to make sure you're getting the most out of it. So why don't you talk a little bit about that on some best ways to stay fully connected with your care team and why it's so important to do that?
Sure. I think I'm just thinking of the reverse, like why we haven't done that.
Okay, well, let's take it from that angle then.
Like I have a primary care physician, or I have someone that is treating some condition of mine, like maybe my finger fell off, right? And I go into my primary care physician, if that's appropriate, and I say, my finger fell off. Please do something about this. I would never say, oh, you don't have time. Okay, I'll go home. Or, oh, you think I shouldn't get a finger because I'm a bad human. I think for so long, we as people that want to get into recovery, whether you call it recovery or not, but this whole issue has been so stigmatized that it makes us shy and it makes us meek about asking for what we need and frankly deserve. And I think that's a really important paradigm shift to wrap your head around even before going into the room with your doctor, your provider, your care team, et cetera. This is something that I wish I had taken more agency and control over my own recovery when I was young and I went to rehab and they said, hey, we're going to throw you into the eating disorder track. You can work on your alcoholism another time. I would have saved myself another 5 years of getting expelled from school, disowned from family, losing all my money, losing my friends. Like it was the wrong path for me. I intuitively knew that. But I thought they were right. It was a white coat syndrome problem where I thought they were right. I was wrong. I was sinful, and I was bad and they were good and they were going to tell me what to do. That right there, everything I just said, it's completely erroneous. Like it all needs to be wiped out. We are the people receiving the service and they are service providers. We get to have control over what happens to our bodies, our minds. We are not bad people. We have an addiction, a physical addiction to alcohol. And I think that's the most important step, kind of pre-provider. But then you have a provider and hopefully you've chosen one, right? I think, Jenny, we were just talking about the huge wealth of provider networks we have compared to 4 years ago, 5 years ago. Like you have more choices. So I think understanding that sometimes it takes a bit of shopping to find the right person. Like if you don't feel comfortable with a therapist, don't tell them your life story. Try to find another therapist. Or, I think we have some more control than we think over our own healthcare care team. And then when you get set up with a care team that you really like, and I don't think you're ever going to be like, oh, I want to marry my whole care team. I love them so much. Like, you can like them, right? At that point, be very clear about what you want, need, questions. If somebody's rude to you, say like, hey, that didn't feel right. I'm just asking a question. Like, I think it's really important to understand that they are service providers providing service to you and they want to help for the most part. And we're all fighting the stigma together. I think if you do come across, and I still do all the time, come across people that call me, use the word drunk or dirty,
that dirty and clean, it definitely, people say it all the time, words matter. but dirty is what you are before you take a shower. You know, but you can't label one person as clean without also implying that anyone else who isn't that is dirty. And so I think that gets lost a lot of times. And I cringe every time I hear the words clean and dirty when it comes to addiction and recovery, because it's the symbolism around that is just so horrible.
It's the connotations. Yeah, it's pathetic. It's a crazy thing to say. You would never call a cancer patient that had metastasized to their liver or something, like say they had breast cancer and metastasized. You would never be like, now you're dirty. You failed your test. You failed your scan, your 6-month scan.
You didn't want it bad enough.
You didn't want
recovery bad enough, so it came back.
You weren't honest enough. You didn't do the work. I think it's important to understand that, like, we're all changing, and we teach people how to treat us, and we teach our providers how to treat us. And if someone says something or does something that you're uncomfortable with, you have the full right to say, hey, that makes me feel uncomfortable, with respect, right? With respect and grace. But, those days are behind us. We don't have to cower to it anymore. So I think just being honest and establishing that early. Dynamics are hard to change once you set them. And, you don't want them to concretize. You want to set the dynamic early. Easier said than done. There's a lot of course correction along the way. It's never too late to change the dynamic, but providers are people. They need to be thought of as humans, not gods.
Yeah, and that it's a controversial subject with some. I usually like to encourage people before their very first appointment to have some level of a goal. Whereas others will say, well, if I'm full-blown critical in my addiction, I don't even have the capacity to have a goal right now. Yeah. But, I usually tell people, if you can look at your provider and say, eventually I want to stop, or I just don't want to lose control anymore.
Right.
That is a great beginning goal, because it at least gets you and your care team on at least a similar footing to begin with.
Yeah.
And so talk a little bit about, strategies to really set that tone in an initial meeting with a provider.
It's a really good question. I think know what pushback is going to be a little bit. Like, if you come in with a goal and it's different from the goal that your provider states. For instance, really early in my recovery, I came in with the goal and said, this is when I was like 16 and I went to a therapist. I said, look, I just want to reduce drinking. I don't want to be blackout drunk at parties anymore in high school. Right. And I remember the therapist being like, when you really want to stop, that's when we'll talk about it. When you really want to stop. And I'm like, well, what the hell happens until I really want to stop? Like, I just have to act like a jackass for, excuse my language, but like, just act like, an idiot until that happens. I'm like, yeah, that's what happens. I like tumble to the bottom in an embarrassing, humiliating way. But I think it's important to understand that that's out there, and that might happen, and to understand like how you want to frame your pushback, right? You can do a few things. One, you can always get a new provider. That's important. In healthcare, for so long, we've thought, oh, this person's covered by my HMO or whatever, so they're the only one. They're probably never the only one, no matter how bad your insurance is or how, whatever. There are a lot of reasons that we kind of stay in stasis. But one, you can change your provider. Two, you can say, that's, if they say you're actually going to have to get fully abstinent, you can't go this harm reduction route, you can say that's not okay for me. That doesn't feel comfortable to me. Period. And like, let them hang with the awkwardness of that statement.
Right. Because, everyone loves to say, we offer patient-centered services. But what you're describing is not patient-centered. If you go in as a patient and your provider is giving you a different goal for you that you're not comfortable with. Now, I'm not talking about one that might be one that you can achieve and might be a little challenging and take some effort. But I mean a goal that you just don't want to have.
Yeah.
You don't see that goal even fitting in your life because you don't. It's not that you don't think you can achieve it. It's that you just don't want that. And there is a difference. You know, if you're letting the provider tell you that that's what your goal is going to be, if you're going to be their patient, then right there, that's a red flag, because that's not patient-centered.
Right. It's not. I mean, patient-centered isn't like I run the show. They're still the provider, obviously. Like you're coming to them for a service. You're coming to them for a reason. But we both turn our keys on decisions. So I think that's important as well. And you might not have the same goal as the provider, but the consensus building has to be there, right? Like you have to be able to talk to them about some way that you feel comfortable of getting to a goal that you both agree on. You know, it's like with my staff, you know, when we set goals for ourselves and for our staff, we don't just say, get it done. You know, like we're not overlords. Like, right, I'm not a psychotic person in the wing saying, get it done, no matter what. You know, it's the same thing. Like they have to agree that it's achievable and hard. I have to think it's achievable, hard, and related to our common mission. We turn our keys and they go and have, you know, great success. But I think that's really important to understand as well as the give and take. And sometimes we're not winning personality contests in those days. Like I totally feel what the person you were talking about said. Like you might not know your goal, but you can say, I expect you to form this goal with me. I don't know, but I'm sure you have some ideas. You see a lot of people like me. Let's talk about it. You know, just there's this idea in psychology of like, do you talk to someone there's a scripting idea. It's like in narrative psychology, but do you talk to someone as a parent or do you talk to them as a child? You want to get on the same level as your provider. And that's really important. Like the provider is not a demigod and you're some sort of supplicant. It's important to just come as two people working on an issue. They have their skill set, but you have your strong area of expertise, which is your body, yourself.
And, you know, and it's your life and your quality of life that you're paying someone else to help you improve.
Yeah, whether you're paying with your own money or insurance, you're paying for it.
So one of the things that we see often, and this is one of those things that we chatted about before we went live, I'll see in peer support groups, somebody will have their first consultation with a provider, and they come to the Facebook peer support groups and they're like, okay, so my provider said such and such, but I'm not really sure about this. What do you guys think? Is this a side effect? Is this, instead of going back to their provider? So from the standpoint of telemedicine, how do you advise people to, yes, you can, obviously, you still want to ask questions and get your peer support in your peer support places. But when it comes to contacting the provider, even before scheduled follow-ups, how do you suggest people go about that?
Well, Jenny, as I told you before we got on this, I'm not a clinician. I want to say I'm not a clinician. I mean, you heard my background. I come from a different world, but running Workit Health, creating Workit Health, and working with providers has opened my eyes. So I work with my care team really differently than I did 5 years ago. I know that providers want to help. Like I do think from all of the people we've worked with, all of the people we've hired, 99% of people go into medicine because they want to help people. It's not for the money or the cash and the prizes or the ego. It might turn into that over time. You have a few bad eggs. Most people want to help. And most of the time we feel awkward because of stigma, because of shyness, because of embarrassment of questions, right? We don't want to solicit that help. I think they've always been sort of put on a pedestal and we're down here. Now, what's happened with Workit is I've realized that like you can actually treat this as any other engagement and seek their care all hours of the night. They might not respond to you, but now I text my providers. I call my providers on the phone, I message them, and like I insist on great care. And I tell them how to get there, and I think that's important. So just know that at any time of night, you might not get a response for a day or two, but you can be as needy, like in quotes, as you want to be, right? Like they're there and they like that. That's their job. They would much rather you say, hey, I need some help right now. I'm really struggling. It's the middle of the night. Can you message me in the morning through my health portal or whatever? They'd much rather you say that than just be there suffering. Their goal is to help you. Their goal is to heal you in some cases, maybe not in this case, but they're there to help. So hopefully that's some sort of benefit.
Yeah, I mean, leading up to our conference, we have a couple of panels that are being pre-recorded, and I did one yesterday. And the provider I was speaking with, he mentioned that the topic was side effects, and he said the thing that makes him most anxious is when someone has side effects and they don't contact him and
Right.
instead want to walk away from it instead of trying to work through things. So, how important do you feel it is in just the staying on track in recovery aspect, having that good communication with your care team?
Oh, really important. Like you want to be a squeaky wheel. This is your recovery. This is your life. Nothing is more important than getting this straight, typically. Like sometimes it's not. Like if you're earlier, maybe this is a problem among a host of problems, right? But this is your life. And I think it's critical to open up those lines of communication, to take a stand for yourself, to know that you're worth it, to know that you deserve the best care possible. Like I think it's all in the mindset. And this is not just from your prescriber. I think it's also from your therapist, and it's from people at the gas station. Like, we can look people in the eye and stand strong despite having challenges. It goes back, I think a lot of this goes back to the moral failing of alcoholism and what we've been taught, which is frankly just outdated and not true. So I think this is coming down a little bit, but I think the onus is on all of us to sort of rise to the occasion and build a better world, one interaction at a time.
Now, at Workit, what is included in the care team?
So at Workit, it depends on what you're coming to Workit for and what level. So we have 3 different levels of service. We have coaching, counseling, and clinic. Clinic has the full Monty, so I'll talk about that. And it's also what we're kind of known for. But the whole idea behind Workit is to get a care team accessible to you at an affordable level, right? Like, so we do a lot. We have a lot of Medicaid coverage. We have a lot of, or Medi-Cal in California. We have a lot of commercial insurance coverage, et cetera. So with that care team, you enter Workit and you get a prescribing provider, either an MD or a nurse. You get a nurse. So you meet with your nurse once a week via video, and you get a full MA team that's at your disposal. So if you can chat us any time of day. So if you have problems at the pharmacy, if you have problems with this or the other, with insurance billing, et cetera, like you can always chat.
What's an MA team?
And a medical assistant team.
Oh, okay.
Yeah. And I think it's something that's often overlooked. We don't have an email that you can email and like it gets lost in some sort of spam folder. You have a live chat and a live team right there if you're having issues. But a lot of this is like, logistically, it's hard. It's hard to arrange your care. You might run into problems, et cetera. So you have that aspect. And then of course you have a master's level social worker. So you have your person, right? You have your person that's working through the psychosocial aspects. And then the last real piece is, 2 more pieces. One, group therapy. So you're invited to go to a group once a week of people that are in a similar stage of recovery as you. Also that have your same coach as you in some cases, but you can go to any of the groups at Workit. And then the final piece, and we do kind of a myriad number of things, right? And some people really love the group therapy and just go all the time, but they don't really like texting their coach. And that's fine. That's what we call our master's level social workers. Other people love their coach, but could like do away with everything else. So we try to find we try to give a buffet of options for people because people have different learning styles, different personality types, different preferences. And so the final piece is our courses, and that's where Workit really started. So we have over 1,000 different courses that, depending on your specific goals, right? Like say you want to moderate your drinking, but stop your drug abuse, right? Like abuse, but stop your drug use or your reliance on painkillers, and you have some trauma you want to work with. We have a curriculum that you can enter that you can do as many exercises as you want, that's self-led, that's based on CBT, DBT, all of those things. So it's a lot for one little app screen, but we pack it in, and we see people get better, and we see people pick up different things. Different things work for different people.
So what's the best way for someone to maximize their offerings in their custom way to meet their own needs?
I just think be aggressive. I think that's the biggest thing. It's like, be aggressive, state what you want, give us feedback. Like, we're growing. We're not, I don't know, Cleveland Clinic. Like, we haven't been around for a bazillion years. We're growing and we're learning and we're trying to be better. And I think as much feedback, if you want to email me, robin@workithealth.com with your ideas, like I'd love to hear them, but just give as much feedback as you can to make it better. Like, we're all building it together. Secondarily, it's just use everything, right? Like, see what works for you, toe dip, try different things out. Maybe you're one of those people that group therapy really works. Maybe you're more like me, where you like one-on-one. I use it a lot for just one-on-one therapy sessions. I like texting, and I don't even like synchronous therapy sessions. I just like async, knowing asynchronous, meaning I can text at any time and I know they'll get back to me, right? Like, I do a lot of that.
I think that's what also appeals about some of the online groups as well, is the fact that if they happen to be struggling at any time of day, because we see that in our peer support groups, the various ones, because of the international following. It's never quiet. Even overnight, we've got our people in Australia, checking in and doing stuff like that. And so, yeah, I think that as you need it, when you need it aspect can be appealing to a lot of people, as can, on the flip side, there's some people who need something that's very structured.
Yes, some people need things that are very structured. And I probably you need different things at different times. Like, life is long, recovery is long, relapsing is long, like, everything, you're just going to need different things at different times. So I think the best kind of rule of the road is know all of your options and know that although, maybe one-on-one therapy works for you at this moment, async texting like me, maybe later, in the beginning of my sobriety, for instance, I was a structure freak. Like, I was like, every morning I wake up at 8 a.m. and I just, I had like my minutes, but it helped me. It helped me put that structure into place, when I felt so chaotic and so just out of control. It helped me control the little things. So that evolves too, and everything sort of shifts and changes. And, I think it's important to understand.
So I'm trying to remember, and I've been doing this with Claudia it'll be 8 years next month, which that alone is hard to believe sometimes.
Congratulations.
How did you guys hear about the Sinclair Method and the C3 Foundation? I don't remember if we found you first and contacted you guys, or if you guys found us.
Contacted you. Well, it's something that we really started with opioid use disorder, and then we went into AUD and medication for AUD. But we started with MAT and OUD. And so when we did go into AUD, we said, what's working, right? Like, what's working in the field, and what are huge areas of growth with harm reduction, what works in abstinence, like abstinence over here. And so what we did is we sort of said, okay, people usually come with one of two goals. Either one of two goals. They never really say, I just want to continue drinking the way I drink. Otherwise they wouldn't be there. They're out, drinking the way they want to drink. So one of two goals. So either moderation is what we call it, and or abstinence. So when I was getting sober, abstinence was the only way. And I think what's beautiful and incredible about the Sinclair method and you guys is you're providing an actual way forward with moderation, right? And even if you want to get to abstinence, you can start with moderation and grow towards abstinence if that's your end goal. If it's not, like, so be it. So that's kind of when we, of course, when you look into moderation, you say, okay, what can we do to wrap around care? Like, what are the best therapies in moderation? What are the best group techniques in moderation? And of course, what is the best medication in moderation? That's how the Sinclair method came up. So I'm sure within our research, I think Callie Lux, our VP of marketing, but also, somebody that's been in recovery for a long time, we already all knew about the Sinclair method. And so she probably recommended meeting you guys. And then I know you talked to her a bunch and off to the races. So that's how we became good friends.
Well, we appreciate it. Yeah, Callie's been wonderful. Fast forward in your mind 5 years. Where do you want to see the state of alcohol use disorder treatment?
Big sigh. I think we just have so much more to go, but we've come so far at the same time. First of all, I would like to see health plans cover alcohol use disorder treatment, period. No questions asked, no ridiculous deductibles, copays, etc. It should be absolved of those things. Like, I think it's as urgent as going to an emergency department or urgent as cancer. Like, this is a serious situation. Whether you want to moderate or abstinence doesn't matter. So coverage is one big goal, right? I'm just going to state the goals. Secondly, I'd like to see not just Workit Health, obviously, like we're not out to build some sort of like antitrust monopoly, but I'd like to see anyone that wants to get help, whether it's moderation, abstinence, or anything in between. Maybe there's a third piece that we're not thinking, and somebody wants to mix it up or whatever goal they have. I'd like a range of options. Maybe they can go to 12-step, inpatient rehab, outpatient, perhaps they can go to Nepal, whatever it is, but they can go to the Sinclair method. They can go to a RIA Health. They can go to a Workit Health. You have like a huge network of telemedicine providers that you can choose from. And that's really important too. And that's important in recovery, feeling like you made the choice and you had a choice in the first place. So those two things. So I would say on the patient level, like, give us options. And then the third thing, of course, is data. I think it would be wonderful if all treatment exposed data. And what I mean by that is talk about success rates, talk about, it's not just like user stories or whatever, architect stories or whatever they are, but like real powerful metadata that's structured in a way that we can analyze it and share across channels and share across companies and enterprises. So longitudinal data sets, releasing them, saying, this is what happens at month 9. This is what happens at month 15. This is what happens 6 years down the road, and really understanding the whole cycle of addiction and cross-pollinating and sharing. And then we all hold hands and we but I could go on, but I think that's enough for 5 years.
Well, some of the comments I'm seeing in the chat here is that your common sense is so refreshing, and unfortunately still rare. And Bruce says, thanks, Robin, for the RIA Health mention. He's actually watching. So Bruce from RIA is out there, our other co-presenting sponsor. Yeah. And we're seeing acknowledgments that yes, universal coverage is needed. But as you and I were talking before we went live, there's like, just going back 4 years ago, I mentioned that yesterday after updating our telemedicine page, when we first started, we had maybe 5 telemedicine providers worldwide. And that was all we had listed. But I recognized, and Claudia recognized very early on, the benefits that telemedicine could bring, especially with the number of stories we were getting from people who said, the only place I could go was the local addiction clinic, and I walked in and I could feel everybody staring at me, and I just felt so judged. And there were people who were walking out before they even had their appointment. They'd show up for their appointment, look around the waiting room, say nope,
Yeah.
and they left. And that resulted in people trying to order their naltrexone overseas, do it on their own, because they didn't feel like there was any support anywhere for them. And as of today, we've got more than 175 individual listings around the world on our telemedicine provider page. We still have some states that only have one provider, but for the most part, we have a lot of states, a lot of areas where you have multiple choices just in telemedicine,
Right.
and that's before you even get to the brick and mortar traditional doctor visits.
Right.
And so sometimes it's funny. People always say, never look back, never look back. The past is the past for a reason. And I always want to call BS on that, because when you're fighting something, whether you're walking the walk of recovery and continuing that journey, which is lifelong, and when you're still critical, it's an overwhelming problem. To those of us who are trying to navigate that system on behalf of others to make it more accessible and less overwhelming, again, in the US alone, they've upped the number of annual deaths from 88,000 a year to I think 95,000 a year. So obviously what's been offered is not working, because the death toll keeps going up. So that's why the more options, the better.
Yeah. Empowerment we can feel, the better. I think that's important too. I agree. I think we should look at the past. So often when somebody walks into a room and someone's looking at you like that, like you're a criminal, you have to know where that comes from. And that comes from 100 years of criminalizing alcohol addiction and sending us to psychiatric institutions and leprosy colonies, etc. Like you have the weight of history. And if you understand that, and you understand what's happened, understanding it as a brain disease, as a non-moral failing, something that like any amount of willpower isn't going to achieve or accomplish, whatever. It's not something to beat. It's something to heal. I think you're better empowered.
Yeah. And I think sometimes pausing to look back at progress and how far you've come is such a powerful thing. I mean, from a professional standpoint, knowing that the problem of combating addiction stigma, getting treatment accessible, affordable, easily obtainable, because let's face it, just because something's available doesn't mean that people even have the ability to use it. But it's so overwhelming that it's easy to see it as the giant mountain that is impossible to climb. And I think sometimes just pausing and looking back, when you can see how far you've already come, it can be inspirational for trying to get even further down the road. And I feel like that is the same with the Sinclair method, which is one of the reasons why we're such big proponents of keeping drink logs, because it allows somebody to look back and see their progress on a rough day, when everything seems overwhelming, when they feel like, I've come so far, but I blew it all tonight. It's like, no, wait, you can look back. And I think looking back is just as powerful sometimes as looking forward when it's done in the right way. And your involvement in our conference is really, a huge thing for us in helping to put that educational outreach out there. I mean, I'm not sure if you've seen our stats on this, but we've got 14 presenters with 13 panels from 6 countries over 2 days. And it's all, thanks to sponsors, it's all free content. Anyone can tune in on Twitch. We're going to keep those videos up on our YouTube. We're going to take those videos and send them out to our presenters to put on their websites to continue the education. Right. Because last week we talked about, was it just last week, ripple effects? I think. Yeah, we talked about creating ripple effects.
Right.
And it takes all of us working together and doing things together in order to make those ripple effects stick and to make them grow. Someone said that at times in the recovery industry, it feels like you're trying to create ripples in honey.
I like that. Yeah. A tidal wave in honey.
Yeah. You get that resistance. So we're thrilled that, that Workit has joined with us to help get this conference going, that RIA Health is our other co-sponsor. And then we've got other sponsors that have come on as well. In fact, we've got a few announcements queued up over the next couple of days. But, it really does take all of us coming together like this to really change minds.
Yeah, I agree. I totally, absolutely, wholeheartedly agree. And the fact that you guys are open sourcing your content, I think it's so noble and wonderful. And I really believe that, if something like this had existed when I was lost and in despair and didn't know what to do and Googling South Florida rehabs, I think I would have gotten sober earlier. I think it would have been incredibly helpful. So, you can never know, but I would think it would be really helpful. So I commend you and thank you so much for having me. I know that we're almost out of time, but
does anyone out there have questions? Questions for Robin? Questions about telehealth? Questions about browbeating your provider into listening to you?
My providers are probably like, no.
All right. Do I still have my delay on? I see people out there. No questions today?
Our conversation was that thorough.
Yeah, I've had that problem before where people are like, no, I've just been so intrigued by listening to what is being said that I didn't even have any questions left.
No problem. No pressure.
Oh, yeah. There we go. No questions. Just thanks for a really engrossing hour. Oh, how do I convince a skeptical provider?
Oh, my God. That's really hard. That's a really good question. Well, I think it's contextual. So I don't know much about it, but I think it goes back to it's not your job to train them on what their medical beliefs are, right? I think that it's important to understand some people still do believe that abstinence is the only way. And this is going to sound easy. And I understand it's not as easy as this, but understanding that you have choices. You can leave that provider, go to another provider. And if you don't have that choice, I think that's important to honor that sometimes we're stuck in the position. I would get at their beliefs and I would say, what's driving this belief? Do you believe, I would just say, what's driving do you believe harm reduction doesn't work? Do you believe that the science isn't there? Well, you have a whole host of evidence against that. But, I think it's important to push on them, talk back.
And I just dropped a couple links into the chat. One is to our Science of TSM page, and that's where we've got our peer-reviewed articles on the Sinclair method and on naltrexone. I've also dropped our secondary website that is specific for medical and mental health professionals, so you can always send them there as well. But as Robin mentioned, and as N. Smith says, sometimes you just got to find a new provider.
Yeah, you really do.
Oh, so Julie, who asked that question, said he describes but tells me he's disappointed at how slow it's going.
Oh,
so yeah, that's one that. I hear that from people, not only where their provider is concerned, they're skeptical, and they don't think it's fast enough. Again, that's a problem of not understanding the science.
What's not fast enough?
Progress on the Sinclair method.
Oh,
If
wow.
it's not working fast enough.
Oh, I think working is fast enough. You know what I mean? Like that's
But
not.
I'll hear that from people who say, "Yeah, my husband says I have 3 weeks for this to work, or
Yeah,
else and it's like that's not actually having bad expectations for the
yeah.
process are it,
So I think the gold standard right now is 2 years of active recovery, right? Like you actually want the process to be slow so it sticks. Like there are no fast solves, just like there are no easy, cheap ways to make money unless you win the lottery. Like, right? Like you want it to be a slow burn so that those habits, those ideas, those things that you're learning are really entrenched and stick. So actually it's antithetical to your goal to make it faster.
and we see that in a few different stages with the Sinclair method. We'll see somebody who I would say, yeah, our average in our peer supports, the self reports are, between 9 and 12 months for actually reaching pharmacological extinction. And then, yes, another year or two for working through all of the remaining habits.
Yeah.
And let's face it, sometimes, addiction, not sometimes, but pretty much almost always, addiction hits other life skills as well. It undermines communication, so you have to relearn how to build communication skills in some when trust has eroded and things like that. And so a lot of triggers can come from
Yeah.
those extra things that are separate from what the medication will do. And so, yeah, we see that. I would say 2 years is a
Yeah.
pretty reasonable. That's a pretty reasonable time frame. That's with both the Sinclair method doing its thing in the moment and working with, as opposed to against, or just letting the medication do all it'll do and
Yeah.
not addressing anything else.
It probably took me 1 year. I always think of the first year as like a physical stabilization year. And it depends on acuity levels, a whole host of things. But for me, the first year was about getting physically stable and extinction. I think I reached a non-craving state at like 12, 13 months. And then I would say the next 3 years were all about why I drank in the first place, right? Like there is a psychological, I believe that there's a psychological component if in some people, and some people they're just physically addicted. I get that. But like, either the drinking caused a lot of problems that now I have to face, or, I started drinking in the first place because of things like, yeah, I think of eating disorder, my story, insomnia. It didn't just appear one day, a drink in your hand and you said, I'm physically addicted. Like it was a slow burn. So I think it's just important to understand, but the longer it takes, the longer it'll last. I think that's something that it's a mindset flip. But I think it's important to remind our partners or skeptics, look, it's supposed to be slow. I didn't become a problematic drinker overnight. And I'm not going to become a non-problematic drinker overnight. I slowly built up to this. I need to slowly heal from it.
So in your opinion, do you think as we continue to get people to step into some sort of intervention, whether it's moderating from a standpoint of like HAMS or smart recovery or medication assisted treatment, as we start to get people earlier in the addiction process, more as a preventative, do you think that 2 years will shrink?
I think it's so contextual and person dependent. I think we're still at a state, I don't think we're in prevention yet. I think we're just earlier in acuity. I think we're so far from prevention. Like I look at like the DARE program, that's our attempt at prevention. Or I look at cancer. It has a really, I think we see a lot of prevention advances when it comes to all sorts of cancers. We know we shouldn't smoke. We know, if you're a woman, we know you shouldn't drink out of glass or plastic bottles. We have more knowledge there. With AUD, I still think we're in the direct intervention and the acute treatment phase, even if like it's farther up the scale. So yeah, I think the 2 years, it could be 2 weeks, but I would tell partners 2 years just to set expectations no matter what acuity level to get people off my back. And real talk, like it's your recovery, it's your life, and it takes a while.
Yeah. Yeah, we do see a lot of people who have those expectations. And I think a lot of that comes from the black and white of abstinence.
Yeah.
You know, the day you decide you are never going to touch alcohol again, your day one, your day two, it's everything, an instant success, whether it stays or not, whether it sticks or not, where it can be a little bit more blurry and nebulous when it's harm reduction and medication assisted treatment, slowing the process down
and
for
even
the addiction.
Like I think in abstinence, what happens quite a bit is that you stop drinking and you're still the same asshole, you know?
Yeah.
Sorry to say it like that, but truly, I mean, it truly, that's what happens. And then your partner's like, well, why are you acting like this? You stop drinking. You know, I thought you were supposed to be better. And you're like, well, I was drinking to calm my nerves. I was drinking for this. And I think even that, like, it might look like it takes a week or a day, but it actually does take 2 years. You know, I think if you really examined it with more of a critical eye and less of an abstinence black and white perspective, we would really see a lot of similarities between moderation and abstinence and the track to recovery.
Yeah. Here's a good analogy, one I hadn't thought of before. N. Smith says, if you get injured playing football, the goal of rehab is to get you back to playing football in a safe manner, not to keep you from playing football forever. So why does AUD rehab have to focus solely on never getting back to a normal, healthy social usage? People won't invest the time to completely eliminate something that can be controlled.
Yeah. Yeah. It's all whether you think it can be controlled or not. And it's all, if you want to go play football, go play football, you know, like, like it's all about your personal goals. So I don't know. I think that's right on.
I thought that was a really good analogy. And I sometimes describe my job description as 50% making analogies. So, so that's, you got one that I had never made there, N. Smith. Thanks for that. Does anyone else have any last questions, remarks? It's a relatively short stream today. Starting on Saturday, we're going to get you guys used to tuning in on Saturday. We're going to do some watch party replay marathons as I continue to get ready for the conference and kind of training myself to be here on Saturdays for 3 to 5 hours at a time. All right. I don't see any more questions or comments coming up. So thank you, everyone, for tuning in today. We appreciate you spending some of your Wednesday with us. If you like what you see, you want to get notified of when we're going live, make sure you follow our channel. If you're feeling generous, go ahead and subscribe. If you have Amazon Prime, you can actually subscribe for free using your Amazon Prime. And we do benefit as an affiliate for that. You can cheer, bit, host, all of that. And we appreciate it. We have links to our other social media channels, our website, and a link to donate in our profile. Never required, always appreciated. And we will see you again next week. For anyone who is a TSM beginner and wants some of your just find the most pressing basic questions you have, we send those in to us. We're going to go ahead. Claudia and I will talk about that on the 26th, if I'm reading my wall calendar right. And Robin, thank you so much for spending some time with us here on our channel. We appreciate you and the work of Workit. And thank you for being one of our co-headline sponsors this year.
Of course. Thank you so much for having me. It was a wonderful discussion. Thanks to the audience for your interesting questions, and the support really means a lot. It's always hard to talk like this. It's just being introverted is a little exposing, but it's such an honor. Thank you.
Thank you. I understand. Given the choice, I would let Claudia do every on-camera behind mic thing possible, but yeah, she would rather have me do all the tech stuff, which means I get stuck in front of the camera as well.
No, it's wonderful. I just every time I meet someone in recovery adjacent, it just feels so much easier. I wish the whole world could talk with such authenticity and realness. So thank you so much, Jenny. I really appreciate it.
Thank you, Robin. And so we've got everybody saying their goodbyes and thank yous, short and informative with lots packed in. Thank you, Robin. Great chat. All right. So bye, everybody. Have a great weekend and be good to yourselves. Be gentle.